Hello everyone, I am Dr. Sakshi Sethia. Today we'll be discussing about ventricular septal defects. In this lecture, we'll cover the anatomy of ventricular septum, based on which there is a classification system of VSDs which will be dealt with in another lecture. Whenever we talk about ventricular septum, we look at it from the right ventricular side of it, with anterior or free wall of RV removed or taken off. I'll mention a few landmarks here before we jump onto the septum proper. This, as I've already mentioned, is the anterior or free wall of RV, on which there is insertion of the anterior papillary muscle. Anterior papillary muscle, as you know, is attached by the chordae to the anteroseptal leaflet or tricuspid valve. So this anterior papillary muscle also gives origin to a band-like structure which originates via two limbs. These two limbs coalesce to form this band, which goes on to insert into the septum of ventricle. This is known as moderator band or septomarginal trabeculation, and it is a specific feature of right ventricle, since left ventricle does not have septomarginal trabeculation or moderator band. Then we have, as I've already mentioned, we have an anteroseptal leaflet, we have an inferior leaflet, or also known as mural leaflet, and we have a septal leaflet. Septal leaflet is attached via chordae to the septum of RV. Now the septal leaflet is specific to right ventricle, and tricuspid valve is also known as septophilic valve, since it has a septal leaflet. Mitral valve does not have a septal leaflet. Tricuspid valve has a septal leaflet and therefore is known as septophilic valve. Then we have an inflow and an outflow, or an inlet and an outlet of RV. The blood, as it flows from inlet to the outlet, the direction of blood changes. And this direction change is facilitated by a crest or mountain or little hill-like structure, which is known as supraventricular crest. Then we have superior vena cava, inferior vena cava, which empty into right atrium. We have right atrial appendage and left atrial appendage, both of which are arranged in a manner that they appear to be hugging the proximal portions of aorta and pulmonary artery. Main pulmonary artery further divides into left pulmonary artery, and right pulmonary artery goes under the arch of aorta. And this is the ligamentum arteriosum, which used to be ductus arteriosum in utero. This is the apex of heart. If you look at this apical four-chambered view, there is a band-like structure which originates from the free wall of right ventricle and goes on to insert into the septum. This is known as moderator band. Again, in this gross structure also, you can see anterior papillary muscle to the septum of ventricle is known as moderator band. Same over here. Now, on the tricuspid valve, basically, as you have seen, it has anteroseptal leaflet, it has an inferior or mural leaflet, and it has a septal leaflet. All these leaflets, they give origin to true chordae tendineae, which go on to attach to the papillary muscle. There are also false chordae tendineae. These are false because they do not insert onto the leaflets, right? They can sometimes be found, obviously they are not universally present, and they can be responsible for functional murmurs. Sometimes they are implicated in VPCs, early repolarizations, and very rarely they can lead to a functional impairment, or systolic functional impairment or diastolic functional impairment. But most of the times, if at all they are present, they are benign in nature. Now coming to the septum proper. Over here in this particular specimen, we have taken off the anterior and inferior leaflets of tricuspid valve along with the anterior or free wall of right ventricle. So what we see is only the septal tricuspid leaflet or STL along with the septum proper. So this entire thing is the septum proper, right? So we have an inlet of RV, an outlet of RV, and the septum proper, right? Septum is basically divided into membranous and muscular. Membranous and muscular. The membranous septum, it is a very thin and small structure. It is around 5 millimeters in diameter. And it is lying in close proximity to the aortic valve cusp. If this is the base of aorta, this is NCC, non-coronary cusp. This is RCC, right coronary cusp. And over here we have a very small structure called membranous septum. It lies in close proximity to NCC and also in close proximity to STL or septal tricuspid leaflet. In fact, STL divides the membranous septum into two parts. We'll learn about that later. Then, radiating out like spokes of wheel from the muscular septum is called muscular septum. So, radiating out in all the directions like spokes of a wheel is the second part of septum called muscular septum. So, we have a membranous septum and a muscular septum. Membranous septum, you should remember, is bound superiorly by aortic cusps and inferiorly it radiates out muscular septum. If you look at this particular septum specimen, this particular thing is the septal tricuspid leaflet. As I had told, the membranous septum, it lies in close proximity to the septal tricuspid leaflet, and septal tricuspid leaflet divides it into two parts. If you notice in this particular specimen, STL is a bit apically displaced as compared to the mitral valve leaflet. The mitral valve leaflet is located basally, more basally, and STL is located more apically. It originates more apically. So, therefore, STL divides the membranous septum into a part which is present above it and a small part which is present below it. This part which is present proximal to the origin of STL is called pars atrioventricularis. And this part which is present below it is called pars interventricularis. The top third portion of the septum is membranous septum and the rest of it is muscular septum, right? So what you need to remember is membranous septum is superiorly marginated by aortic valve cusps, NCC, RCC, and inferiorly it radiates out muscular septum. Now coming to the muscular septum, it is divided into inlet, trabecular septum, and outlet. Imagine this is the STL, septal tricuspid valve leaflet. If this is STL, and these are the chordae, the chordae insert over here. This is the limit of septal tricuspid leaflet attaching to the septum with these chordae, right? So, the inlet septum, it lies between the two AV valves, tricuspid and mitral, and beneath the membranous septum. So, just below the aortic valve cusps, over here we have membranous septum lying between the two AV valves and beneath the membranous septum, bound inferiorly by STL chordae, is the inlet portion of muscular septum. And the inlet portion is also located posterior-inferiorly. The second part, which is trabecular septum, it originates from the membranous septum and is extending up to the apex of heart. It is the largest part of intraventricular septum and it does not lie in one particular plane. So you need to look carefully in multiple different views to comment whether or not there is any defect in trabecular septum. The last part is the outlet septum, which is the anterior superior part of the septum. So the anterior superior part is known as outlet septum. It lies anterior to the trabecular septum and inferior to the great vessels or to both the semilunar valves. If you look at this particular diagram, we have a posterior-inferior region of muscular septum which lies between the two AV valves, is inferiorly bound by septal tricuspid leaflet chordae attachment to the septum, and this is known as inlet septum. Then radiating out from membranous septum up to the apex of heart, this entire thing is called the trabecular septum, which is the largest part. Okay? Again, towards the outlet portion, just beneath the two semilunar valves and anterior to the trabecular septum is the outlet septum. So outlet septum is superior anterior and inlet septum is posterior inferior. You can remember all of this via this particular mind map or table. The rest of it, the classification of VSDs, will be dealt with in the next lecture. This is my YouTube channel. If you like the present video, please do share and subscribe. Thank you.